Hello, this is a PowerPoint on schizophrenia, which is a disease, and this is by Coryn G. and myself, Jasmine B. Clinical indicators of the disorders according to standard nosology. According to the DSM-5, schizophrenia is a disorder that is distinguished by significant disturbances in thinking, perception, and behavior. These include two or more of the following, each present for a significant portion of time within a month. At least one of these must be delusions, hallucinations, or disorganized speech. Other characteristics include grossly disorganized behavior and negative symptoms, i.e., diminished emotional expressions or avolition. In the ICD-11, there is a stronger emphasis on the disturbances that may occur. When we were using the ICD-10, it was coded under number F20, and subsequent codes ranging from F20 to F20.9. That covered a full diagnosis of schizophrenia from paranoid starting at 0, continuing with disorganized, catatonic, undifferentiated, residual, and lastly with schizophrenia unspecified at 20.9 in the ICD-10. When we went into the ICD-11 as a blanket category of primary psychotic disorders, its code became 6A20 and continued with schizoaffective disorder at 6A21, schizotypal disorder at 6A22, acute and transient psychotic disorder at 6A23, and delusional disorder at 6A24. Schizophrenia is characterized by disturbances, intuitive mentalities, and requires symptoms ongoing for a minimum of 1 month, but it is projected out into a 6-month period because there is a lot of misdiagnoses with schizophrenia, primary being diagnosed as either depression or anxiety. Although there isn't a clear cause of schizophrenia, it is believed to originate during gestation and in less than ideal environmental factors during pregnancy. Prevalence and incidence. According to the World Health Organization, or WHO, schizophrenia affects 1 of every 30 or 0.32% of people across the world, and that's for the global population. It typically begins during the late 20s and into the early 30s, and is often found more in men than in women. And then this is due to estrogen levels. Obviously, men have lower estrogen levels, higher testosterone. What they're finding is that as women begin to progress into perimenopause and menopause, estrogen levels drop. And if there was a preeminent diagnosis or they had previously been diagnosed with some sort of psychosis, schizophrenia begins surfacing and the markers and symptoms of schizophrenia become more apparent as estrogen drops. Due to their mental health, schizophrenic people are 2 to 3 more times more likely to die earlier than others in the general population. Factors that influence this are early death rate, are often related to physical illnesses and addiction or substance abuse. That is because there's a lot of issues in getting, number 1, schizophrenia properly diagnosed. Number 2, finding the right combination of medicine and treatment. And number 3, getting them to come in to really follow along with their treatment. There's a lot of issues there. Prevalence and incidence continued. It's noted that approximately half of those diagnosed with schizophrenia have other mental or behavioral health issues. Again, schizophrenia is comorbid with depression, anxiety, and any number of antisocial disorders. And this created a stigma around them that they are hard to manage, violent, or dangerous. Schizophrenia is also often misdiagnosed, as I said, as dissociative identity disorder, which is known as DID. Which also perpetuates stereotypes because then it is assumed to laymen or people that are not familiar with the way diagnoses work, that they may just be someone else at another time, and so we don't need to really invest ourselves in helping to treat this individual or finding care for them. Stigmas can lead to socialization, which schizophrenics are known to self-isolate. And then this perpetuates a lack of services. Oftentimes there is discrimination against schizophrenics because, again, they're seen as hard to treat, hard to manage, oftentimes violent, misdiagnosed with something else that may be more of a combative nature. Schizophrenics are transient in nature and are found wandering a lot. And this can bring shame and fear into their lives, which perpetuates an ongoing cycle where treatment is really just not solid and continual. Most individuals who suffer from schizophrenia do not receive proper mental care. According to Johns Hopkins Medicine, at least 1% of the U.S. population is diagnosed yearly with schizophrenia. Causes of schizophrenia. Causes of schizophrenia at present are mostly unknown. Though there does seem to be some presumption and a small amount of study leading to the accepted belief that it is a combination of the brain's chemistry, genealogy, and environmental factors. An earlier onset of schizophrenia in a fetus could be due to deficiencies in essential nutrients and micronutrients. These could be vitamin D, folic acid, and iron. There is study during famine to support this theory, though there would still be some sort of genetic cursor or marker present in the fetus beforehand. Schizophrenia may become evident later in the life due to neuromitigation and connectivity, which would be the synaptic connections being disrupted, especially those in the cortical striatal, which mitigate dopamine activity. And that is directly related to a lack of folic acid. Of course, vitamin D and iron are major roles in the development of a fetus, but folic acid is what brings the actual fibers and neurostructures of the brain together. Common developmental courses. There are 3 developmental coursal stages: prodromal, active, and residual. In the primary stage, subtle changes in behavior, mood before full psychosis. It is typically misdiagnosed or believed to be depression because they're all the same symptoms. Subtle changes can include social isolation, which is found in depression, of course, a lack of hygiene routine. Also, when people are severely depressed, clinically depressed, they do not put themselves first and they're not interested in how they look. And a decline in performance. Obviously, if someone is depressed, they're really not interested in, making that meeting and looking their very best and challenging themselves. They're not in that place. 2 is the active phase, which is prominent positive symptoms such as hallucinations and delusions. Without proper treatment, these episodes can last for months, and stressful events combined with life occurrences can easily trigger an episode. And so that's why they look around, they continue to look at 6 months down the line, because maybe the person is misdiagnosed. Maybe there are more comorbidities than what were assessed to begin with. During, again, the prodromal phase, the changes occur before full psychosis are communication diminishes in general, which communication may not be optimal to begin with because they have to learn social cueing and are not developmentally socially adequate, as we'll see in the next slide. That is an issue for schizophrenics, especially if they've had early onset or adolescent schizophrenia. During the active phase, the positive symptoms are delusions, hallucinations, disorganized speech, disorganized orientation, and or catatonic behavior. Catatonia may be mistaken as just severe depression. Some people don't like to talk when they're sad or depressed, and that could be misleading. The negative symptoms are flattened affect, loss of pleasure, lack of motivation, and social withdrawal. All of those could also be found in depression, and even with anxiety. When someone is having an anxiety attack, many times they just want to be by themselves. They don't want to talk to anyone. They want to be left alone. And you will see a reduction in the normal behavior during negative symptoms, whereas in positive symptoms, these will be in addition to the person's normal experience. The residual phase. Prominent negative symptoms such as a lack of motivation. Patients can flip between this phase and the active phase. So they present more prominent, and that will be a lack of motivation. Patients can go back and forth into the active phase during this time. And you see that here on our diagram on the upper left corner, We see that it's showing minimum to max, between subthreshold to diagnostic, to where we can really, the symptoms are truly presenting themselves, and we're seeing less of the person themselves and more of the disease of schizophrenia under symptom intensity. We have the waves 1, 2, 3, as we see the brain waves reacting to that. This is, again, things are not firing as well between the large and the small fibers. The lack of the dopamine, maybe GABA inhibitors are involved. There's the brain's chemistry is off kilter, to say the least. And this booster hit, this is also during the residual phase. This is just the terminology they chose to use on this graph. Down here at the bottom, we have from the very beginning of conception all the way to about 50 years on here. Unfortunately, schizophrenics have a shorter lifespan as they are subject to more diseases, as oftentimes their immune systems are not optimal and they are born with other deficits in their health care, certainly emotional and obviously mental deficits as well. Pre-adolescent schizophrenia, negative symptoms become prominent around this time, where we see it says functional impairment. As we look at the age timeline chronologically, this person is in their adolescent period. This is when adolescent schizophrenia would present itself. For others, though, as we saw with women, this may not come into perimenopausal time down here. In men, this would be more indicative of a male's experience with schizophrenia. As we're reaching our 20s, we're in our late teens, early 20s, we're leaving us adolescence into adulthood, isolation, stress, and drug abuse as our roles as in society and our family dynamic may begin to change. We might see more of those schizophrenic symptoms become evident. At-risk mental state, negative symptoms linked to poor social integration and educational difficulties. The person is not able to take care of themselves more than likely, and economically is going to have to start seeking some sort of assistance or become homeless, which we will discuss later on. We see that this is where we're seeing the psychotic crisis occur. This can occur at any stage, but the most severe psychotic episodes typically happen when the full-on diagnosis would present itself, and that would be between the years, for males, between, typically, not to exclude females, 22 and 23 years old. And this is a crisis. Here we are at the residual stage. There's opportunities in these areas to try to redirect, try to refocus on other things, but we have to be buffed up on our patient and know exactly what it is that would be able to bring them out of the cycle, and be very careful not to trigger them and bring them right back into another episode if they're already in the residual phase. There could be persistent negative symptoms, which would become deficit syndrome. Deficit syndrome refers to a subtype where the individual will continually experience negative symptoms. And that is why it says here, negative symptoms pronounced and not improved, even when psychosis is well treated. And that is why a strong support group and program and perhaps living atmosphere in some sort of a group home or facility may be the very best choice for a person dealing with deficit syndrome. In our next graph, we have schizophrenia is the most common type of psychotic illness. 56% of males and 33% of females with a psychotic disorder will, overall, 47% of them with these psychotic disorders, it will be schizophrenia. So that's almost half of our population with a psychotic disorder is dealing with schizophrenia. 63% and 42% of males and 42% of females with a psychotic disorder will be assessed as abusing or dependent on illicit drugs. That's where our previous graph, it shows isolation, stress, drug abuse. This becomes very common and prevalent as schizophrenics will try to self-medicate, and if they're going through ad nauseum, then they may not even realize that they have schizophrenia and that the delusions they're suffering and the experiences that they're having are just very true and real and typical for everyone on this planet. The mean age of onset in men is 23 years. For women, it's 24 years. Again, that has to do with the estrogen, but it does not exclude women as having schizophrenia in earlier years either. 1 in 10 males and 1 in 4 females with psychotic illness are married, are living in a de facto relationship. Okay, this touches again on the social dynamic and the educational difficulties, as well as the poor social integration. They may also have a learning disability. This is not uncommon with schizophrenics. They could also be dyslexic. They may have a hard time with comprehension because they do not have concrete reality. Many times it is very difficult for them to work in logic. They have difficulty troubleshooting and thinking through difficulties. They have clouded thoughts, clouded thinking, a lot of brain fog. And so those are all barriers in understanding how to navigate the difficulties of a relationship, adding to further discomfort and concern and self-isolation, depression. Oftentimes these end in divorce, or the person just abandons them altogether. They just have to have a strong support group to help them through these issues. Government persons main income source for government pension, main income source for 85% of people with a psychotic disorder. This is because, again, if you're having a hard time with socially integrating, you're having a hard time comprehending, which means learning. So you would need to be able to comprehend what your new roles are at your job, even if it's just something as simple as working at a fast food restaurant. And you're getting overwhelmed, you're comorbid with depression to begin with, and you don't have a lot of motivation, and perhaps the program that you're working has gotten you a job. More than likely you're going to quit within the next 30 days. Maybe you'll be rehired if the community is working with a specific place of employment. Maybe you won't. Maybe you don't want to be rehired, but certainly you can get onto some sort of services. And it has been my personal experience that all of the patients I've dealt with having some sort of schizophrenic disorder are on SSI. 58% of males and 39% of females with a psychotic disorder are assessed as abusing or dependent on alcohol. Again, in our first graph, we showed where more than likely the time period, which is the adolescent period where people are going through peer pressure. Schizophrenics may want to belong. They may want to begin self-medicate. They think that they're feeling better. As we studied earlier in the chapters with addiction and whatnot, where alcohol people believe that it's going to make them do better. They have more, mental prowess and physical ability when they're getting drunk. This is no different for schizophrenics. We know that alcoholics often turn towards other gateway drugs, and then this can turn into a full-on addiction, especially for those schizophrenics that don't have a strong support system, that may have no place to live, and so on. Prognosis. Prognosis varies upon the individual and different variables. Variables that can improve prognosis include functioning before diagnosis, gender, a strong support system, age of diagnosis, and sobriety. Variables that can worsen prognosis include gradual symptom development, substance abuse, and prominent negative symptoms. About 20% of individuals attain crucial recovery, and 40% have partial improvement with ongoing symptoms. Some people actually can completely remit all symptoms and have quote-unquote normal lives, which is wonderful, but again, at 20%, that's few and far between. Although schizophrenia remains a lifelong risk for most patients, an advance in intervention programs, antipsychotic medicines, and psychosocial rehab have significantly improved the prognosis for many individuals compared to previous statistics in the past decade. The goal is not only to reduce symptoms, but to also restore daily life functioning and quality of life. Yes, we have grown in leaps and bounds in the psychiatric community in treating those with schizophrenia through medicine, support, therapy in general. There was a time when people that had schizophrenia were thought to be demon possessed. Assessment. Psychological therapies are typically offered in the form of cognitive behavioral therapy and family therapy for the support of the relatives who have been affected by these individuals' battle with schizophrenia, as well as social skills training, which is helpful in facilitating quality social interactions for these individuals. Yes, again, the support system cannot be spoken of enough. If you can gain a schizophrenic's trust to some level, then that is golden to them, because then they will, when they are going through these times where they're hearing other voices perhaps, or they're seeing things, or they're hearing things, if they can recognize someone that they have allowed themselves to trust, this is pivotal. There are also the contributions of Dr. Carol North, MD, Dan Fisher, PhD, MD, and Elizabeth Baxter, MD, who openly shared and are currently sharing documentation experiences with schizophrenia. I believe Dr. Carol North has passed away, unfortunately. There are many schools prevalent in the continued research of schizophrenia. A few schools of note are UC Davis, Harvard University, Miami Miller School, Johns Hopkins, Icahn School of Medicine at Mount Sinai, Columbia University, and NYU Langone Health. These doctors that were brave enough to not only openly admit that they have schizophrenia, but also to document and film their lives as schizophrenics, are a wealth of knowledge, not only because they are patients, but also because they're doctors. They're giving us a dual viewpoint. We see how it is to be treated and how they would like to be treated with their disease, but also as a doctor looking at someone with disease, how they would treat themselves, and are very active in their own treatment. Treatment. Since schizophrenia is multifaceted, there are a number of ways that treatment has been evidenced. The first would be using antipsychotics such as haloperidol, chloroprocaine, and olanzapine. Second-gen antipsychotics such as clozaril, olanzapine, and risperidone. Finding the right combination and dosage is different for each individual, as each individual is unique. Electroconvulsive therapy has been considered for individuals in combination with antipsychotics if those antipsychotics are not effective, and sometimes they are not. Some people need very extremely high doses to even touch their episodes. I've seen others where they started them very high and it made everything worse, and they had to titrate down to an almost non-existent level, but that level was perfect for that person. So it is definitely individual, case by case. There are also many social support groups for the individuals themselves, as this is a lifelong disease and many are experiencing anosmia, not realizing that they're suffering from schizophrenia. Again, many schizophrenics unfortunately go undiagnosed or are misdiagnosed, and to them, their experiences are very real, and which they, of course, they are. That is their reality, but they think that they have to live like that. That is how everyone is experiencing life, and until they're correctly diagnosed and treatment begins, they don't really get to have that basis of comparison as to what it is when they are living with schizophrenia, and then when they are in a relatively non-symptomatic pattern. Evidence through these practices came from work by Dr. Emil Crane, who first described the disorder in 1869. So that's the first year that schizophrenia became a diagnosis. Eugene Lear created the term schizophrenia in 1911 by documenting, and psychological aspects were brought together by Dr. Karl Brandt in the Nazi area, which he studied schizophrenia extensively. And unfortunately, although he did bring a lot of great work to light, he did execute his patients afterwards. The use of chloropropane as an antipsychotic, which changed the treatment of schizophrenia, even to this day, was pioneered by Jean DeLay and Peter Denneker. So definitely antipsychotics have a massive role in treating the symptoms of schizophrenics. I hope that this was of some use, and I pray we continue to look into the future of schizophrenia, always forging ahead, and perhaps at some point we can find an actual infallible treatment and cure for this disease. Thank you for your time.